Good day, my name is Michael Rooks. I'm coming to you from Port Orange, Florida. The topic of today's presentation is functional anatomy of the hand. The human hand is a miraculous structure. It is our primary method of manipulation with the external world. Understanding the hand's unique anatomical structure and how it relates to function is a prerequisite to recognizing and treating illnesses, injuries, and anomalies of the hand. The extensor tendons have to deal with the same torque forces and imbalances as the flexor tendons. However, the solutions are more intricate and varied. With the flexor tendons, the main functional features are related to balancing the different torque forces and keeping the moment arm stable. With the extensors, stability becomes a major feature in the anatomy. The need for stability against volar dislocation of the extensors limits the options for dealing with the torque issues. There are 7 extrinsic finger extensors. 2 exist for the thumb, the extensor pollicis longus and extensor pollicis brevis. There is also 2 for the index, the extensor indicis proprius and the index extensor digitorum communis. There is an extensor digitorum communis for the long and ring fingers each. There is often 2 tendons to the small finger, but both belong to the extensor digiti minimus. There may be a small tendon from the extensor digitorum communis of the ring finger connecting to the small. The extensors of the lesser digits are connected by junctura tendinae over the distal metacarpals. There is often extensor digitorum communis interconnections over the proximal metacarpal/distal wrist. Independent extensor digitorum communis function is limited. The minor digit metacarpals are connected distally by deep intermetacarpal ligaments. These connect at the volar plate flexor sheath regions. The dorsal junctura tendinae appear to assist the intermetacarpal ligaments with stabilization of the metacarpals in grip. The extrinsic extensors cross the metacarpal phalangeal joint and insert at the dorsal base of the middle phalanx. An attachment to the proximal phalanx is absent. There is often fibrous attachments to the metacarpal phalangeal dorsal capsule. If the tendon was attached to the proximal phalanx, a tenodesis of the proximal interphalangeal joint would exist, severely limiting PIP joint motion. The tenodesis problem is resolved with the extensor sagittal bands. These are attached to the extrinsic extensor tendon just proximal to the MP joint and insert volarly at the base of the proximal phalanx an MP joint volar plate/flexor sheath. The bands attach to the extensor tendon more proximal. The cross-sectional area that the sagittal bands must surround is narrower in extension, allowing added proximal extensor excursion. With flexion of the metacarpal phalangeal joint, the area increases. This requires extra distal excursion of the extensors to increase the sagittal band cross-sectional area. This extra excursion allows for PIP joint flexion with MP flexion and takes up the slack with MP joint extension. A further function of the sagittal bands is to stabilize the extensor tendon against volar dislocation over the MP joint. The extrinsic extensors do not directly attach to the distal phalanx. Motion in the DIP joint is linked to the PIP joint through a couple of anatomical mechanisms. The conjoined lateral bands link PIP and DIP joint motion. With PIP joint flexion, these bands sublux, effectively shortening the distance between the conjoined lateral band origin and the terminal tendon distal phalanx insertion. PIP joint flexion/extension thus contributes to DIP joint flexion/extension and vice versa. The conjoined lateral band receives tension forces from the intrinsic muscles and to a lesser extent the extrinsic extensor. The 2 muscle groups are linked through the dorsal aponeurosis. A secondary static link exists between the distal and proximal interphalangeal joints. There is a pair of oblique retinacular ligaments that serve a similar, although static, function as a tenodesis between these 2 joints. These originate volar and proximal to the PIP joint, inserting dorsally into the terminal tendon. There are multiple retinacular ligaments in the finger that serve to stabilize the extensor mechanism over the phalanges. These include the dorsal aponeurosis over the proximal phalanx, the triangular ligament over the middle phalanx, oblique retinacular ligaments, and the transverse retinacular ligaments. The intrinsic muscles of the hand are necessary for proper functioning, both in flexion and extension. They provide all of the abduction and adduction force in the minor digits. MP flexion, IP extension, and MP stability fall within their venue. The intrinsic muscles of the hand are composed of 4 groups. These are the lumbricals, the interossei, dorsal and volar, the hypothenar, and the thenar muscles. The lumbrical muscles takes origin from the flexor digitorum profundus tendons of the minor digits, inserting into the radial aspect of the digit's dorsal aponeurosis. The tendon travels just radial to the profundus and volar to the intermetacarpal ligament. The index and long fingers have a unipinnate muscle arising from the same profundus. In the ring and small fingers, the muscle is bipinnate, arising from adjacent tendons. This results in limited independent motion between the long, ring, and small digit profundi. This lack of independent motion is further hindered by frequent interdigital connections in the carpal canal. Significant independent profundus motion is limited to the index finger, and this is more uncommon than common. Flexion of the IP joints requires eccentric contraction of these muscles. Isometric contractions result in IP extension and transfer of profundus tension force to the MP joints. Because of the lumbrical origin from the profundus tendon, any added MP flexor torque is negated by the lumbrical's negative effect on the profundus MP flexor torque. In effect, the lumbricals are IP extensors working in concert with the profundus flexors. The lumbricals can often offset the loss or absence of the sublimus tendon. Congenital absence of the sublimus in the small finger is fairly common. Dorsal interosseous muscles are bipinnate, originating from the adjacent metacarpals. They serve to abduct fingers away from the midline of the long finger. The first and second dorsal interosseous muscles insert on the radial base of the index and long finger, respectively. The third and fourth interosseous muscles insert on the ulnar base of the long and ring fingers, respectively. The volar interosseous muscles are unipinnate. They are 3 in number. They originate from the same digit metacarpal as their insertion. They adduct towards the long finger midline and are found on each metacarpal except the long. The index volar interosseous has an ulnar insertion, while the ring and small finger volar interossei have radial insertions. Interosseous muscle tendons travel dorsal to the intermetacarpal ligament, but volar to the MP axis of rotation. They may insert into the dorsal aponeurosis, into the base of the proximal phalanx, or both. There is a lot of discussion among anatomists regarding this issue in any given interosseous muscle. Generalizations include that dual insertions with a conjoined tendon are common, radial insertions are more likely to be to bone, and ulnar insertions are more likely to be to the dorsal aponeurosis. Dorsal interossei are more likely to have a more prominent or bone-only insertion. Volar interossei are more likely to be tendinous. The possibility of a proximal phalangeal bone insertion is a consideration in performing an adequate proximal release in intrinsic contractures. Interosseous muscle provisions include lateral finger motion, MP flexion, and IP extension. Working with the extrinsic extensor, they also dynamically stabilize the MP joint against volar subluxation in a fist. With IP flexion, an isometric interosseous muscle will produce MP flexion, coordinating the motion between these 3 joints. Varying the contractile force will modulate the MP flexion. Unlike the lumbricals, the interossei can add MP flexor force. Paralysis of the interosseous muscles results in loss of lateral motion, MP hyperextension, and IP flexion, and intrinsic minus hand. Any discussion on hand biomechanics would be amiss without a brief discussion of the collapsed deformities of the fingers. Whenever compressive forces are placed across two or more joints, there is a tendency for the involved segments to collapse into a zigzag pattern. This is a problem frequently encountered in the fingers, toes, and the wrist. In the fingers, these collapse patterns are referred to as a boutonniere or swan neck deformity. Boutonniere deformity results from loss of the central slip over the PIP joint. This can result from trauma, infections, and inflammatory disorders. PIP joint extension is lost. With time, the extensor aponeurosis will migrate proximal with the loss of DIP joint flexion. Subluxation of the conjoined lateral bands will lessen any extensor force they have at the PIP joint, and eventually they may become PIP joint flexors. The transverse retinacular ligaments will contract and further limit any dorsal migration in the lateral bands. Fixed flexion contracture with possible subluxation and arthrosis of the joint is to be expected. The opposite collapse pattern is a swan neck deformity. This deformity requires laxity or absence of the PIP joint volar plate. It may result from several other causes, however. Loss of the terminal tendon at the DIP joint, a mallet finger resulting from trauma, infection, or other causes can lead to a swan neck deformity with proximal migration of the dorsal aponeurosis. Absence or loss of the flexor digitorum sublimis can also lead to a swan neck deformity. Intrinsic spasticity or contracture can lead to this deformity. Subluxation of the MP joint seen in inflammatory arthropathies can result in swan neck deformity secondary to shortening, loss of extension, and subsequent tightness in the intrinsics. In individuals with lax joints, swan neck deformity can occur spontaneously. Similarly, the deformity can occur after injury or loss of the PIP joint volar plate alone. Loss of the terminal tendon, a mallet deformity, can be ruled out as a cause for a swan neck deformity with the return of active DIP extension with passive PIP joint flexion. Possible sublimis loss can be evaluated by active flexion of the PIP joint with the remaining fingers held in full extension to block the profundus. The Bunnell intrinsic tightness test will rule out intrinsic etiologies. If you have made it to this point, congratulations are in order. I sincerely hope you have found something of use in this presentation. Thank you for your attention and thank you for your time.